Thank you to everybody that's organised today. I hope the information could take hours and hours and hours to deliver. And the most unpleasant topic I have to talk about is chemotherapy, which usually fills everyone in the audience with fear. So I am technologically incompetent, but here we go. Next page. I think that's that one. Right. How do I, done? No. Oh, do I use this? Oh, it's turned up there, but it hasn't turned up here. So when you mentioned, huh? Go back. Back. I don't know which way I'm going now. Okay. Starting. Okay. Right. Okay. We're ready. So the word chemotherapy evokes dreadful kind of visions in people's minds, things they've seen on television, relatives, friends that have had chemo. And one way I tell my patients to think about chemotherapy is to think about antibiotics. Now, we give antibiotics to kill bacteria in blood. They can be delivered either orally or by intravenous infusions. And what chemotherapy does is, the aim of chemotherapy is to kill cancer cells in the body. We might give chemotherapy as one drug alone, but in some rarer tumours there may be combinations, and different drugs are used to treat different kinds of cancer. So what your friend with breast cancer suffered from her chemotherapy treatment is completely different to the drugs that you'll be offered for a brain tumour. There are over 100 different chemotherapy drugs that we can use in the clinic at the moment. Unfortunately, if you have a urinary tract infection, we can send it off to the lab, get a report back and say this is going to fix up that bug. And we don't have that luxury with brain cancer or any forms of cancer at the moment. We do have some simple tests, however, that may predict which tumours are more likely to respond than others to certain kinds of chemotherapy. And research is aiming to be able to use sophisticated molecular testing to unravel what is driving these tumour cells, where may they be susceptible to attack with drugs, and if there may be some new targeted therapies out there that we can think of in the future instead of this broad smack chemo which affects most dividing cells in the body. Brain cancers, however, have some unique problems we need to consider. Normally, the brain is protected by a barrier to stop infections and toxins getting in, to protect the most important thing in our body. It's called the blood-brain barrier. And if we're treating a cancer in the bloodstream, like leukemia, we simply have to pick up a needle and squirt some chemo into the blood and it'll get to all the different targets we want to get to. But if we're going to try and treat brain cancer, we have to try and deliver these drugs across the blood-brain barrier. They need to be a certain size and shape, and they need to pass the barrier in high enough concentrations to actually knock down the tumour cells. And different cancers are susceptible to different drugs. And this is because cancers start out from a normal cell, they then divide, make a genetic mistake, and the different genes within your cancer cell determine how quickly the cancer divides, where is it able to invade and live, and how it affects other tumours. So we are really looking for where are the weak spots and how may we be able to affect those weak spots with drug therapy but spare most of the normal tissue in the body. What kills breast cancer does not necessarily kill brain cancer, and it's much like antibiotics. You don't use the same antibiotic for every bacteria that comes along. Unfortunately, the number of drugs that fulfil the criteria of being able to cross the blood-brain barrier, kill brain cancer cells, are very limited. And research is looking for new drugs and taking into account what molecular pathways we're unravelling in these different tumour cells, and how might we be able to find their weak spot and attack. And sophisticated development, not only in the biology lab, etc., but engineers and chemists can really look at the target and now manipulate drugs to be a certain shape, a certain size, etc., that may well get across the blood-brain barrier and then start attacking where they want them to be. So finding new therapies, new drug therapies, is a combination of a host of different scientists, not just the biologists and things, which, you know, we're really hoping. They've been very slow to give us a new drug that I can put on my desk and hand to patients, but certainly as all these teams come together, things are developing quite rapidly. So what now? To decide on what drugs a patient should be given, first, as an oncologist, we need to know what cancer are we actually dealing with. And there is 100 different kinds of cancer that start in the brain. And for the likes of poor old Michael Rodriguez up the back, who's a neuropathologist, it can be very challenging for them to make a diagnosis by just looking down the microscope. So normally when you're diagnosing bowel cancer or breast cancer, you can get a pretty good idea of what you're dealing with. But if you send some complicated tumours to 5 different experts around the world and ask them to analyse them with a microscope, you might get 5 different results. So we've now aided by being able to send them off for some limited molecular testing, and that can start separating them out and help us determine where should we go from here. Molecular testing takes time, and it's very frustrating for patients and carers to be told by your doctors, well, we just need to wait a little bit longer for another week or so while we get these tests back, so then we can decide on what treatment you're going to have. The most common kind of brain cancer are gliomas, and most of them, unfortunately, are high grade. That means that most of them need radiotherapy. So while we're waiting for these sophisticated molecular tests to come back, we can hand the patients over to the radiation oncologist, and they can start making their plans. And so they're ready to go, and we can know whether we need to add chemotherapy now, later, etc., etc., etc. So some patients will need chemotherapy at the same time as they're having radiotherapy. Others will have radiotherapy, and we will then follow them up with chemotherapy once the radiation has completed. Every now and then there are some tumours that will be treated by radiotherapy alone, and there's no point in adding drugs in for them. And so your doctors will decide on what drugs should be given and when they should be given, what schedule they should be on, and that's mostly guided by pathology, but it's also based on information we've gleaned from clinical trials in the past that have said if you do ABC versus XYZ, you're going to get a much better outcome. What dose are we going to prescribe? So we have a very crude mathematical formula which is based on how tall you are and how much you weigh. And we do this little thing on a calculator and come up with your body surface area, and once we have that, we then try and calculate the dose. But everyone is different. Some people may be on regular medications that can interfere with the metabolism of drugs or actually cause significant complications when given together. Some people might have kidney or liver problems, or diabetes, which can also complicate things. Some may have chronic viral infections, which we need to take into account. Older patients tend to metabolize drugs a lot slower than younger patients. And also, when you're treating brain tumours with radiotherapy, you may, Suko may give you a 5 square centimetre field or a 30 square centimetre field. And as the blood flows through your radiation field, it's actually knocking down a lot of your immune cells. So the bigger the field, the more impact the radiation might have on your immunity, and we need to put all those things together to work out what would be the best dose for individual patients. Dexamethasone changes the metabolism of most of the drugs we take, as do some of the seizure medication, and so that can either keep the doses too high for too long or make them too low for too long. And deep vein thrombosis and pulmonary embolism is a common complication for people with brain tumours, and patients may be on blood thinners, which we need to know about. If their blood count on platelets, which are the ones that stop you bleeding, goes down from the chemotherapy, and you're on blood thinners, there can be problems. So all these things need to be taken into account when a doctor's writing up a dose. Temozolomide is the most common drug. Unfortunately, it's now been around for 20 to 30 years, and we haven't really had anything to replace it. So it comes in capsules, needs to be taken on an empty stomach. During radiotherapy, it's taken every day, and then following radiotherapy for high-grade gliomas, it's taken for 5 days a month. It can cause some nausea and vomiting, but with the modern anti-nausea pills, nausea and vomiting is extremely rare. It's also very rare to cause hair loss, so patients may come to us with a patch from the radiotherapist, but within a couple of months, that's all started to grow, even though they're still on radiotherapy. Still on chemotherapy, I'm sorry. But side effects vary from patient to patient. It's very rare that people have an allergy to temozolomide. I think about 1 in 1,000 I've seen. It can sometimes affect white cells, which fight infection, and platelets that stop people from bleeding. That happens in about 1 in 100 patients. And in my practice, 1 in 100 patients are female, and in about 2,000 patients we've given this drug to are men. So there's something really weird about the way women and men deal with this drug that no one knows the answer to. We can't test people who are going to be very sensitive to it, but when it happens, it can be very dramatic. So your doctor will be monitoring your blood count. We do it weekly because I'm neurotic, but some do it fortnightly, and they get away with it. And if we do see changes, we may ask people to stop drugs, hold drugs, and reintroduce them at a later date. Other kinds of gliomas, oligodendrogliomas, are a rare form of primary brain cancer. Their diagnosis needs molecular testing, so before you can get a label of an oligo, you need to have the molecular testing sorted out. And major trials for treating oligodendrogliomas started 30 plus years ago, and Temodol didn't exist. So we used a combination of 3 drugs, procarbazine, lomustine, and vincristine. Vincristine is actually given as an IV infusion. The other 2 are oral. But because these tumours are incredibly rare, it took forever to gather 300 patients, some that had radiotherapy alone, some that had radiotherapy with plus chemotherapy. And then when we've got all the patients randomised onto the trial, we then need to wait for 10, 15, 20 years because they have a very good prognosis to work out whether or not the chemo has added anything or not. So the initial analysis of these studies said that chemo wasn't adding anything. You were just fine having radiotherapy and we'll give you some chemo down the track. Then when we followed the patients up to 10, 15 years, we showed that you double survival by having the chemotherapy as part of the adjuvant treatment. So these trials, if we're ever going to compare temozolomide, which certainly has less side effects than the PCV chemotherapy, the results won't come out while I'm still here. So it'll take 20, 30 years to answer that question. Some oncologists feel that they just give Temodol, and a lesser study showed that it was equivalent if you give 8 cycles of Temodol versus PCV. But others feel that they've got to go up to level 1 evidence and offer PCV, and that's an individual choice by the doctors working in the field. There are many other cancers needing different drugs. Some of them develop and look like childhood cancers. In general, they look down the microscope like childhood cancers, but they are driven by different genes in adults. They're extremely rare and extremely challenging. We often turn to our paediatric colleagues for help. But what we need to remember is adults are not just big kids. So you just can't take the dose that you're going to prescribe for a child that has much faster metabolism and gets them out of the system quicker and put them into an adult without causing major difficulties. So you can't just translate one to the other, but you can certainly get some advice from our colleagues. Because we deal with the drugs differently, and the genetics, even though they may look the same as a childhood cancer, may be quite different as well. People will have heard of Avastin, Bevacizumab. It's an antibody. It maps up a hormone. Brain cancer cells produce a hormone that causes the blood vessels to leak, and with all that fluid in the brain, you get brain pressure. The normal drug that we use and try initially is dexamethasone, but if you need to stay on dexamethasone for a long period of time, its side effects can be just as bad as the pressure, and we may recommend Avastin. It has side effects. We need to use it with caution. It's not on the PBS, which means that your patients are up for $20,000 for the first 6 doses. If they are responding, it's free for life. After that, courtesy of the company. And we've heard that generics are on the way, which will mean the drug will probably be a half or a third of the price, and it may even get across the PBS. But everyone in the room agrees we need better treatments, which will only come from research. Research often starts in test tubes or on bench tops, moves into animal models, and then finally needs to go into clinical trials. There's been dramatic improvements in the way we can molecularly analyse tumours. Things that took 5 years are now taking 3 weeks, so we can get information back pretty quickly. Hopefully these will guide us in finding new drugs. Some of the drugs need new discovery from the chemists and the engineers. Some of them may be already out there for treating other diseases like worms and be repurposed and potentially go in as a therapy for brain cancer therapy. So that's called a repurposing indication. At the end of the day, however, they all have to go into proper clinical trials, and trials are dependent on patients volunteering to participate. It's an enormous sacrifice to go on a clinical trial for both the patients and the families, keeping in mind it won't be a trial if we know it works. So you may be signing up for something, it sounds exciting, but there's absolutely no guarantee it works, otherwise everyone will be already getting it. And it may have some unexpected side effects. At the moment we are working on trial design, so instead of taking 5 years to recruit patients and then try and get a result out of it, if we could take fewer patients and get results much quicker, that means these will move into the clinic much quicker rather than, sitting around and hoping and still trying to recruit forever and a day to work out whether they're any use or not. And it means less patients are going to be exposed to less of therapy that might not work. Now, the major excitement in the oncology field, I'm sure everyone's heard of, is the success we've had with immune therapy, particularly melanoma, but now in some other kinds of cancer. And there's not a day that goes by in my practice that a patient doesn't tell me they're taking vitamins, complementary medicines, and special diets to boost their immunity. And they get really insulted when I say to them, which part? The good part of your immunity or the bit of the immunity that's protecting your cancer against immune attack? And they go, what? What are you talking about? So as tumours that arise in the brain have some unique immune protective mechanisms that differ from other cancers, and cancers that actually start in other parts of the body and spread to the brain. And all this needs to be taken into account when we're designing new immunotherapies. They develop from normal cells, as I said before, and the only way, when a cell starts to develop and go along a pathway to become malignant, they will be taken out by a normal immune system unless one of those mistakes they've made is to set up a barrier and protect themselves against immune attack. So very early on in the piece, to exist as a cancer, these cancers have already got themselves a mechanism where they can evade immune attack. And they do this by secreting certain molecules. We found out in brain cancer, they secrete molecules which goes into the bone marrow, recruits a certain population of bone marrow cells that goes up, sits around them, and forms a barrier to any kind of immune infiltration, and paralyzes any immune cells that come in their direction. They can hide from immune cells by making themselves pretty invisible, and their brain cancer cells don't have a lot of abnormal markers on the outside, little signposts to say, hey, I'm not meant to be here, take me out. Melanoma has a bucket full. So that's one of the reasons this therapy has been more successful in melanoma than it has been in other cancers. So I also think of a brain cancer looking like a Smartie, because if we do a biopsy of site A, B, C, D, E, F, G, do the molecular analysis, we may find different molecular pathways active in the same lump. And we might be able to wipe out A, B, and C, but we can't wipe out D. And unless we get rid of the whole lot of it, we're not going to be successful. Using combinations with radiotherapy and chemotherapy, which attack in different directions, can help, but are not always, as effective as we'd like them to be. So there's always some little bright blue Smartie that we can't see there, sitting, hiding, get rid of everything else, and we've still got that other one to deal with. And they can switch off from immune attack. The markers on the outside, we can't see them. And it took me ages to find this, but there is actually a snake in the middle of that patch, hiding away from everybody. And we can't see it. The cancer cells can be the same. They're sitting in the middle of the patch, can't see them. Immune cells can't get to them because they don't know they're abnormal. Gliomas also have different protective immune immune cells that are protecting them, and the different protection you can kind of think of like a castle wall. You just need a long ladder to get over that one. But, you know, if you're trying to get into the middle of a moat, you probably need a boat and a bit of hiking gear to get over the top. So immune therapy is not all the same, and it needs to be tailored to what you're trying to attack. All is not lost. We just need to work out better how to harness the immune system to attack gliomas. We have seen some rare gliomas respond beautifully to common garden variety immune therapy. So we know if we can get it in there and we're using the right drugs, there are some patients that have done extremely well, but it's like 1 in 20 million rather than 1 in 2, which is 1 in 1 is what we want. We need to get the gliomas to show up more targets, and this can happen with radiotherapy or chemotherapy. We kill the cells, they burst open, the targets all become visible to the immune system, and you set up like this vaccine in the middle of your tumour for attack. We need good mechanisms to knock down what is protecting them. This may be new antibodies, and there is one study that showed that chemotherapy that makes your immune cells go down before they come up actually allows the good immune cells to come back first and go after the baddies. We need to recognise that everyone's immunity is different. It's determined by the genes you inherited from your parents. And, you know, if you commit a crime and they get some of your white cells down and do DNA analysis, you can get committed for the crime because you have an individual marker on your forensic analysis. Immune cells can cause harm doing nothing. Diseases like diabetes, multiple sclerosis, because your immune system's turned against parts of your body and started to attack and taken them out. Immune therapy comes in lots of different forms: vaccines like a flu shot, dendritic cells, which is taking your circulating blood cells out, multiplying them up in a test tube, adding some stuff that tells them to recognise A, B and C, and then infusing them back. There's a bit of hype at the moment about CAR T cells, which are your immune cells manufactured to attack parts of the cancer surface. And there are some new drugs coming along that we're hoping will activate the paralysed immune cells or destroy the cells protecting them. It's certainly a very expanding field, and we really need not to make the same mistakes we made with chemotherapy. We didn't realise how different it was to get chemo into the brain, and we need to realise there are unique things about brain cancer that are not the same as melanoma in the toenail. And we need to take this into consideration when we're starting to look at new treatments. Immune cancers in other diseases are not without major side effects. So, you know, just having an immune shot doesn't fix everything up. And I spend my day resuscitating patients from the melanoma unit down the road from us that come in with these major complications that can sometimes even be fatal. So if you really switch your immune system on to attack your brain, you can get diseases like encephalitis and multiple sclerosis. We all want these new therapies now, not in 20 years' time, but if we don't take time to evaluate them and do them properly and think about what we're doing, we will miss out, and we need to evaluate the successes, we need to evaluate the failures, because the failures will tell us just as much about what we haven't done as about what we should be doing. So lots and lots of work to do. We want it on the table now. We have to take a bit of time to sort it out, otherwise it'll just come and go and not be used efficiently and be another flop. Thank you.